was a little nervous. So I had my wine here with my little bee thing that I think one of the patients
Oh,
gave me.
you're drinking
Isn't that
wine?
cute? Yeah, well, I'm not in the office, so I can have my wine.
Yeah, yeah, of course.
Um, so, Dr. Dev, so I just thought that it would be cool to interview you because so many patients and we have so many advocates out there always wanting to interview you, give some input. But then I think that I have a lot to say. I have a lot to ask you, or just even have more access to so many patients that want to go ahead and ask you things that they'd love to know to maybe make a decision for next year, the year after that, or maybe even patients that have had surgery already, maybe just pop on up and talk about their experience or maybe ask a question. But I just want to say that as one of your patient coordinators, I'm extremely, extremely proud to work alongside with you. And it really warms my heart every day to know how many patients we're helping. Did you know, and the girls from the office today were running around and I said, how many surgeries, how many explants or combinations did we do? We did over 550 so far.
Oh,
This
wow,
year
this
alone.
year.
Did you know that?
I had no idea.
Yeah, I know you didn't know that. I didn't know that either.
It
So
felt
I
like a
think
lot, but great.
just this year alone.
That's
So that's
amazing.
pretty awesome. And we had patients coming in from all over the world. We had Sweden, we had Dubai, we had from the Caribbean, Colombia, Brazil. I just, it goes on and on, all the United States. So that's pretty cool. It's
Canada,
pretty cool.
Africa, Mexico,
Africa,
Finland.
Mexico. Yes. Uh-huh.
Very
So
cool. Yeah,
how do you feel
we've
about
done it.
that? How do you feel about that?
I mean, it's very humbling. You get to meet people from all walks of life, and it's definitely an honor. I never take it for granted. When you start doing surgery, you kind of hone in on your something that you're very passionate about, and to be able to help people from all walks of life, it's been really a humbling experience. I'm truly honored, and I'm glad that they have you in their corner to help navigate through what's a very complex kind of scenario that we're in. So
Yeah.
yeah, truly blessed.
I feel the same way. It's incredible. It's incredible how many patients are coming in. I mean, it just seems like everybody's wanting to explant. Like it's just so many more patients are just coming around these days, and I feel like
Yeah.
for health reasons and just because it's preventative.
Yeah, I mean, if you look at the statistics that have been done with the societies that we're in, with the American Society of Plastic Surgery, the number of explants has risen quite a bit. A few years ago, it was up by 8%, and then it went up by 31%. So I think the awareness about explant is definitely out there. People are knowing that it's an option. I think the biggest thing when we started doing this 6 years ago within the private practice setting was that it was never given as an option. People were talking about exchanging or doing something to keep their implants in, and the option to explant was always kind of shunned away. So that know-how through social media, patients themselves being their advocates for other patients, has definitely been a boom in this particular procedure. And the satisfaction rate, as we know, is very high. I mean, people
Oh,
are
extremely,
the
extremely.
ladies, they
I tell patients all the time, patients are so afraid to how they're going to look, and I always say, you're going to be surprised at how quickly you adjust to the new you and actually love it.
yeah,
So yeah, once in a while we do have patients that miss having that fullness.
yeah,
But I would say for the most part, including myself, it was a very quick adjustment, very quick.
yeah. And your 4 years coming tomorrow, your
Yeah,
4 year
no, on
anniversary.
Wednesday. Wednesday it's the explantiversary.
13th. Yeah, yeah, yeah.
Yeah, I'm
That's
excited about that.
amazing.
Yeah. So, well, I know a lot of the patients ask, I think the biggest thing is, do I explant and do I lift afterwards, and what kind of a lift?
Yeah,
So if you can maybe explain, we're kind of do like tiny little consultations here so people can understand a
sure.
little bit between why not lift, who's the better candidate to just explant, and then the type of lifts.
Yeah, when we talk about explants itself, why patients want to remove their implants, there's multiple reasons. One is they're just tired of having them. They've had them in for, say, 10, 15, 20, 30 years. They just don't want the weight of them on their shoulders, on their chest, and they're not part, it's not part of them, so they want to remove their implants. Capsular contracture, these hard rocks on the chest, ruptures, leaking implants, and then we're seeing a lot of patients with autoimmune issues related to the foreign body or the implants, commonly referred to as breast implant illness. So these are some of the reasons that we're seeing patients come see us to discuss the explant process. And then when they make that decision to explant, then we have to kind of evaluate their breasts and see if they're a candidate just to explant only, which means removing the implant. And what I like to do is remove the whole capsule, total capsulectomy, and plus or minus to doing a lift or not. And the reasons to do a lift are if the breasts have fallen down with time, there's a lot of loose skin, the skin needs to be tightened and the breast kind of be like I like to say be brought up to a happier spot. Then that's where we start talking about the lift. And then, once you get into the decision, okay, are you a lift versus no lift, then the algorithm goes into what kind of lift are you a candidate for. And so there's a lot of different type of lifts out there. The one with the least scarring, which I think an explant is most feasible to do, is in a lollipop lift. So that's the incision that goes around the areola and up and down. Beyond that, there's like a mini anchor type of lift where there's an incision on the bottom. There's a full anchor lift. There's an
So how do
extended.
you distinguish who the better candidate for one is as opposed to the other? Like for the explant with the lollipop,
Yeah,
why is that candidate better? What's the
yeah,
difference?
yeah. It just depends on how their breasts have fallen. So if the breasts have fallen so much that there's so much loose skin on the bottom of the breast,
Okay.
and so if you just do a lollipop, you're basically bringing the areola, the circular portion, to a higher spot. You're making it smaller most of the time, and then you're making one incision going up and down, and you're basically bringing the breast kind of closer together and up higher. But if they have loose skin on the bottom, then the lollipop doesn't really address that loose skin, and then you're gonna have what I call like a Snoopy type of breast, so it's just kind of longer breast, and so you have to reconstruct the bottom portion of the breast. And so if there's a lot of loose overhanging skin and the tissue's fallen quite a bit, then that kind of leans them more into the anchor type. I always, my goal is to always start with the lollipop lift and see how it looks after the implants come out. And then I mark the patients as if they're going to get a full lift either way. And then if the tissue tells us that the tissue needs to be removed from the bottom and that whole, what I call the mammary fold, the fold
Mhm.
between the breasts and the abdomen needs to be reconstructed, then that's where we convert to an anchor style lift.
So without giving away your secrets, how the heck do you lift a breast with just a horizontal incision?
Oh,
'Cause
yeah.
that's a hard one. That's a hard one even for me to explain because it's like
Yeah.
magic. Like how do you do that?
Yeah, I actually learned the horizontal lift. I think it's only an incision on the bottom of the breast, and not everyone's a good candidate for it.
Right, right.
If the breasts have really bottomed out, meaning the implants have stretched the breasts out so much on the bottom that almost the breasts are like sitting into the abdomen area, then I like to do a horizontal lift. And so there's two goals of the horizontal lift. One is to get rid of all the skin on the bottom of the breast, so that addresses the tissue stretch, and then I have to reconstruct or hike the mammary fold back to its normal position. And in doing so, whatever breast tissue is there, I kind of push it up to fill in the space where the implant used to live. It's a challenging lift in the sense that you have to really know exactly where the fold is going to end up because it's been stretched out. So if the just for measurements and being a little technical, say if the normal distance between a patient's nipple and the breast fold is say 7 to 9 centimeters, if somebody's breast fold has expanded to where it's 15, 16 centimeters, so you have that's a big tissue stretch. So you have to figure out where to reposition it. And we have like special sutures that we use to help reconstruct it. All this I learned honestly when I was doing breast cancer reconstruction surgery in training, and I kind of adopted that technique and implemented it for our explant patients. But the
Do you
nice
feel
part
that training
about
gave you a bit of a gain on what you're doing now? Just like,
I mean, it gave me a good option. So it added to my toolbox of things that I can offer patients. And you know, with plastic surgery, the least scarring, the better. You know, when you
right.
make scars around the areola, the vertical scars, you know, they're all scarring. So we want to try and minimize scarring, but achieve a good outcome as far as the actual explant goes. Um, so that's where the horizontal lift really came in, and I kind of adopted techniques from that breast cancer reconstruction training that I did and implemented it. And I think the results have been really good. I mean, I think
They're
patients are really
phenomenal. I
happy.
mean, patients are super happy, and when I talk to them about that option, they're very happy to know that they can at least try that first, or even
Yeah,
like when we talk about just explanting, because I feel that patients hesitate. They want to do this so bad, but they're scars. I'm so afraid. And
yeah,
when it is an option and they can do explant only or horizontal lift, it's like a big relief because
yes,
that fold just hides everything nicely.
yeah,
Um, but even when it's a full anchor lift, I feel like it's the difference in how patients are feeling. Number one, I think that's the number one. Uh, some of them just don't care. But then at
yeah,
the end, they look in the mirror and go, you know what? I really actually like this. I really like how I
yeah,
look, and
yeah.
I'm adjusting quickly.
Yeah,
So
it's a twofold procedure. One is doing the explant and feeling better from that, but for us, it's really important to get a aesthetically pleasing result. Because I mean, once you feel better from the explant, say if you have autoimmune issues or pain and this and that, then you're gonna after 3 months you're gonna look in the mirror and you want to look good, and so that's where getting that aesthetic breast reconstruction is really important. You know, for us to so it's kind of it's a nice mix of plastic surgery because there's a reconstructive portion and then there's the aesthetic portion of it.
how do you handle, I know that these are some of the questions that patients ask, how do you handle when you know that the patient has a rupture as opposed to not knowing? Is there a difference?
Yeah. No, you know, we treat every patient as if both their implants are ruptured. Um, because you know, there's rupture is one thing. We also see a lot of gel bleed, which is an interesting phenomena where there's so much wear and tear on the actual implant shell that silicone almost kind of bleeds out of it, and then this capsule is sticky, and then when you cut through it, you don't find a rupture, but it's all sticky. So you know, we try to minimize contamination of the actual breast pocket with silicone, because once that silicone leaks into that breast pocket, it's a big mess. I mean, you get silicone leaking into the breast tissue. It can go to the lymph nodes. It form granulomas. Patients can have reactivity to the silicone. So we want to try and get everything out without contaminating the breast tissue, and that's the goal. So you try and achieve that. If it's ruptured, you know, obviously you really spend a lot of time um, making sure you try and get that whole capsule intact without any spillage or leakage. And so,
Right.
but that's the goal for every
Yeah,
surgery.
which you do a great job at. I always tell
Thank you.
patients, like, don't worry, he's going to get that. Um,
Yeah, you know, and then they ask us, like, what if you can't get it out intact? And usually the situations where it's difficult to get it intact is if the capsule is stuck in certain areas. And the two areas that I think that they really can get stuck in is the central portion of the rib cage and the armpit region. And if they're stuck in those areas and you can't really see it, you know, you're really you can risk complications. So that's when you kind of convert into this controlled total capsulectomy situation where you have to remove the actual implant from the capsule without contaminating the actual tissue and then getting the whole capsule out safely.
in some of the videos that we send to the patients, so everybody knows, Dr. Dev takes the time to recorded video of his capsule cutting ceremony. And so you can see that the explant was done properly and en bloc in the cases that he can do. But oftentimes you talk about inflammation, and how does that make the surgery more difficult when the patient has a lot of inflammation inside?
Yeah. No, then we can see inflammation from multiple reasons. If the actual foreign body reaction or autoimmune response is there, the tissue is really kind of swollen and it's stuck onto certain areas. If there's a rupture, it's always stuck all over the breast capsule, the breast tissue. And then if they've had multiple surgeries, if they had 3, 4, 5 breast surgeries, there's always scar tissue in there. So that makes it very challenging because you can't distinguish between normal and abnormal tissue and capsule. So you just have to take your time in those cases and just really spend some time peeling everything off. And yeah, I do these videos for everyone for 2 reasons. One is because I think it shows them, we're transparent, that, okay, your
Super
capsule was thin,
important.
your capsule was thick,
Mhm.
this is what your capsule looks like, um, and so it gives almost kind of like that live confirmation that, okay, here's what's come out of it and
And
this is what it
patients
looks
really
like.
appreciate that. They really love it. Every evening, I literally,
Yeah.
before I send the videos, I'm already asking me, where's my video? I want to see my video.
Yeah. Yeah, and then I give a little explanation of what I see and what I've seen during the surgery because before I used to always go into the recovery room. I go in the recovery just to check on patients, but they'd all ask what happened, what'd you find, and I'd explain it, and then the family member would explain it, and there would be a lot of confusion, and so it just is kind of a nice summary of what we found in surgery, and patients can look back and listen to it so they get a good understanding of what happened during their surgery. So it's almost a summary of their operative report, so to speak.
Today, you and I spoke about a case where you actually went digging behind the muscle because this patient had implants placed over the muscle.
Hmm.
And then, but her previous surgery to that, you found the capsules that were left.
Yeah.
Can you talk about that a little? Because I thought that was so interesting.
Yeah, if patients have had multiple surgeries, like 2 or 3 or 4 surgeries, where the implants say were placed above the muscle at one time and then underneath the muscle, most of the time the capsules are left behind. And these capsules they'll say like, oh, I had a rupture before, and I don't know if they took my capsules out, and I don't like to leave those capsules behind. So when I do the explant, say the patient we were talking about, she had her implants above the muscle. Both of them were ruptured, so we took those out in one piece. And then she had mentioned that she had capsules underneath the muscle. She had a history of implants. So I just kind of went to the side. I didn't cut the muscle or anything. I could sneak in from the side. And I found the pocket where the capsule was. And it just kind of shrunk and contracted. And it was kind of tethering on the muscle. So I ended up just kind of cleaning out that whole capsule and removing it. So my goal with the surgery is that to kind of clean the whole pocket so that scar tissue capsule is all kind of removed, and then you try and restore as much normal anatomy as you can.
Do you think, let's say someone like that with an MRI show the capsule that they had previously?
Nah, that's a great question. Sometimes it can, but if it's a thin capsule, sometimes you might just see scar tissue over there. If there's a fluid collection, then you'll see it. If it's calcified, then you'll see it, but not every time. So the history is more telling. So the patient, if she's like, yeah, I've had my pockets exchanged, then I'll usually go and kind of peek in those areas where the different pockets are and see if there's any residual capsule behind.
What about patients often ask mammogram? Should I get a mammogram before my surgery? What do you think?
It depends. There's a lot of discussion about mammograms and thermograms and
Right.
radiation.
Mhm.
My personal bias at this time is I have you don't if you've had a mammogram done um, according to the guidelines within the year before your surgery, you don't have to get a repeat mammogram. So if a patient is 40 and is looking to explant, has never had a mammogram, I suggest getting a mammogram so you can get a roadmap of what your breasts look like. So the short answer is if you haven't had one and you're due for one, then yes, you should get it before. Um, because we've had 2 patients who we found cancers in,
Right. Mhm.
and so it's good to get your imaging because if there's an issue with cancer and stuff like that, that needs to be we need to get that taken care of before we explant.
And then after the explant surgery, explant lift, how quickly or when can they get the mammogram if they didn't get it before?
Yeah, I'd say wait for about 6 months. 6 months is usually the time frame that they can venture into doing it. If you don't have any risk factors, like a family history of breast cancer, personal history of breast cancer, that or anything that a radiologist has suggested as far as getting imaging every 6 months, then you can wait for the full year. But anywhere between 6 months and a year is when you get the mammogram.
And then what about breastfeeding? I find that more and more young women are getting their explant and they're just like waiting and they're asking, when can I, after I stop breastfeeding, how quickly can I explant? Because they're like dying to get rid of these implants and they're just want them out, but they want to make sure that they take care of the
Yeah.
baby first.
Yeah, no, that's a good question, and the scenario comes up. So we have explanted a patient who was breastfeeding actively, but she really needed to get her implants out, and
Yeah, I
for
remember.
partic yeah, so we we did the explant only in that situation. It's underneath the muscle, so you typically don't have to violate any of the breast tissue.
Okay.
But if you're looking for a reconstruction, then you don't wanna do it when the tissue's engorged with milk and you want the tissue to really settle and the swelling to go down. So I like to wait for about 3 months for breastfeeding to be complete, so for everything to settle and kind of tighten up, and then do the explant with the lift.
Okay. What about, I'm just going in my mind what patients frequently ask. I know like exercising, kind of going back to, I think they can drive after a week after their drains are out.
Right.
But what about exercising? And then we have the girls that are like CrossFit and they just like, "Rrr," they can't
Yeah.
wait. When is it realistic to go back where, because we've had like late onset hematomas because people are going into working out too quickly. So what's safe for going back to
Yeah.
working out?
I mean, we have general guidelines, but the golden rule is listen to your own body.
Right.
But our general guideline is at 4 weeks, you can start lower body exercises and upper body stretches. So range of motion, kind of moving your arms. And then between 4 and 6 weeks, once your range of motion is good, then you can start doing resistant bands to start working on your muscles and opening up kind of your muscles. And then after 6 weeks, you can start kind of using more weights. So we'll start with maybe 3 to 5 pounds, 5 to 10 pounds. I usually say by 3 months,
Hmm.
the CrossFitters are back in it.
Yeah.
I mean, we've done some bodybuilders, and
Yeah.
they're tough because their muscles really take a long time to heal. So for bodybuilders, I usually say, if you're looking for 100% muscle strength, think about gaining 10% muscle strength every month. So usually by between months 10 and 12, you'll get to your full muscle strength.
Do you feel that the bodybuilders and the girls with the little amount of tissue are more likely to have denting? And and if so,
Yeah.
what is denting exactly, and what can they do to help it, and how quickly?
Yeah, the unfortunate dent is it's usually from severe tissue stretch from the implants and then just lack of tissue for reconstruction. So if you think about it, you have say if somebody who has a pre-existing A cup gets implants and the implants just stretch out the tissue and they want to explant and they just don't have a ton of tissue to reconstruct it with. So, you know, you take them out and you try and push in tissue. You would use our kind of special techniques to push in tissue into where the implants used to live. And if you just don't have enough scaffolding or tissue to put it in there, then you get these kind of dents. And there's two type of dents. I think there's concavities where the natural breast kind of concaves in, and then there's actual dents where it looks like there's a line going across and it sinks in. And so those things, and some of those we can actually see and try and predict preoperatively when we're doing the marking. So that comes to counseling patients and talking about, hey, you're at a high risk for a dent. And we do our best to try and fill in the space with your own natural tissue. But if you can't, and you basically there's nothing left behind, then we teach them things like cupping and massaging afterwards to help prevent the actual skin or tissue from sticking onto the chest wall. And then as we get towards the 9 month or the 12-month mark, then we start kind of counseling them about fat transfer as a natural option to fill in that dent or that concavity.
But if it's with the muscle animation, is it going to help a lot, or is it something that they just need to accept?
Yeah, I mean, some people have to accept the muscle animation, the pull from it, just from not having tissue. Though people with muscle animation also, we filled in fat and released the scarring in that area and filled it with that scaffolding between the skin and muscle, and that's worked out pretty well. Though you still see some animation. So it's a tough situation because cosmetically it doesn't look great. You know, and sometimes it can affect the area from a functional standpoint. But the dents happen just from extreme tissue stretch and lack of tissue.
You know, a question that comes across: why does a patient have to wait if they want to do fat grafting? Why wait a whole year? What's the
Yeah,
difference? Why can't you do it on the same day?
yeah. I mean, and the reason I know that because I used to do it on the same day, and I just think it's a horrible procedure. So, you know, when you do the explant and a lift, you know, you're taking out the whole capsule, you're reorganizing the tissue. The tissue is super swollen. And now you're injecting fat into swollen tissue, and it's hard to inject it because the tissue is so tight. So you can't really get good amount of fat in it, and then everything's swollen. So you really just don't have a good cosmetic gauge of where to inject it. And I can tell you, I mean, I can from doing it, it looks great on table. And the first week it looks amazing. We're all high-fiving. You're like, oh my God, this is the best thing. It's swollen. And then like 6 weeks come by and you're like, oh my God, what's going on over here? And then you get to 8 weeks and then you start losing everything. And so you haven't done any justice to the patient. Now you've taken all their healthy fat, full
Yeah, now you don't
liposuction.
later on have anything to
You're
work.
screwed. Yeah, you're screwed. So a year goes by and then you're like, okay, where do I get good fat from? Now I have liposuction fat and scarred areas, and then I've lost fat over here. So I just think it's a bad procedure in my opinion. I know a lot of people do try and do fat grafting at the same day. We've actually explanted patients who have had implants and a lift and fat grafting done at the same time. And when I've gone in there, there's you can see maybe a few specks of grafted fat. And I was like, how much did they inject? And everything was full and looked great in the beginning. But I would love to see, you know, other docs who are doing fat grafting at the same time. I'd love to see their 1 year results and see how much fat has actually survived. And my personal opinion is a lot of it doesn't at the same time.
Well, and not to mention, and something I discuss with the patients is that I'd say that 9 times out of 10, they're inquiring about it. But had they
Right.
gone through the procedure and maybe risk of infection, risk of complications, but if they never go through it, they're actually really happy and they never move
Yeah,
forward
yeah.
with the fat grafting. Isn't it true? How many
Right.
patients ask us about fat grafting at consultation? And 9 times out of 10, these patients never move forward with it.
They
They
don't
just
need
end
it.
up saying, you know what? I love it.
Yeah,
It's not what I thought it was going to be. I'm
yeah,
happy. I no longer want, I don't need it.
exactly. Yeah, you know, I mean, there's two sides of this coin. One is, I mean, who wants to do another procedure a year from now? You know, they've just recovered from the explant, they're back in their mojo, they feel great, you know, and then the cost of there's
Sure.
costs involved, which we have to be very cost conscious with our patients too, and then recovery. So you know, it's a big thing to swallow. But yeah, you're right. I mean, I'd say 9 out of 10 definitely are
Yeah.
happy and are like, you know what, I'm good. Let's move forward, and they're happy with where they're at.
Yeah, yeah. I don't like to like discount with their concerns, but I can almost tell, predict the patient that's not going to need it. And I'm just like, we'll talk about this a year from now. We'll see. But
Yeah,
no, we
yeah,
have to talk about it. I don't want to feel like I don't care, but it's like I just can tell like no, she's going to be just fine. And I
yeah,
always tell patients too, when we think you're not going to be just fine, we're going to counsel you a little bit on it, and we're going to talk to you about it and what your options are down the road. So if we don't address it, it's because we think that you're going to be just fine without it.
yeah, yeah,
Yeah. That fat grafting is something that even we have patients that have never had implants, and we're also doing that type of fat grafting, which has become really popular now too, because less and less women want implants now. And
yep,
it's out. The word is out there, and I love when those patients come in too, because these patients are like, okay, I want a little bit of fullness, but I do not want the complications or possible outcome of having implants in my body.
Yeah.
So those girls are coming in more and more now too. The younger girls with wanting to just do the, how do you feel about those? Do you like those? Are you liking those girls
I
coming in?
I think those are great. I mean,
Yeah.
one, they're not putting foreign bodies in, and then yeah, you have to be realistic though with the volume of fat you can get. So I usually say you can try and achieve getting half a cup size to maybe a full cup size with fat transfer. If you're looking for that kind of papao upper pole fullness, fat transfer is not going to give you that. It's going to enlarge your breasts, and you'll get a little bit of contouring and maybe some excess cleavage, but it's you're injecting natural fat, which is softer than what an implant is. So you have to kind of explain some of those things, because some people think that, oh my God, they're going to get the same kind of carbon copy result. And the other bonus with fat grafting is you get liposuction and
Oh yeah,
contouring.
that's the
So
plus.
so some patients actually they appreciate that even more.
Mhm.
So I think it's a win-win situation. The big thing is people talk about complications of fat transfer, and so you have to kind of talk to patients about things like fat cysts and potential fat necrosis and infection from the fat transfer. The one thing that I think are scare people is breast cancer and fat transfer, and they did some studies out of MD Anderson, which is a big cancer institute in Texas, and they didn't find any increased risk of breast cancer with patients who are doing fat transfer in all groups of patients who have had breast cancer, who have not had breast cancer.
Think it makes a difference when they do a mammogram?
Yeah,
Does it even show
no,
up? Actually, I
yeah,
didn't even know
no,
that. Does
yeah,
it
it makes,
show up as a
yeah, yeah, you
grafted
can
breast?
see.
Yeah.
You can see the difference, because breast tissue and fat from the abdomen, they have a different morphology, um, and then you're gonna see some scar tissue, but you have to let whoever's reading your mammogram know you had it done, because you can sometimes see calcifications from the fat, and you might see little specks of what they call fat necrosis, or fat that hasn't survived. So there's some of those nuances that you have to look at. But I think it's a great procedure overall,
Mhm.
as long as the expectations are realistic.
Mhm. Do you think explanting is going to fade away? Is this something that it's a big thing now? It's just going to go away? No, right?
Never, no.
Me neither.
Yeah, I think unfortunately, breast augmentation is still one of the most widely performed procedures.
Yeah,
Um,
because you know what? These little girls are growing up and they're still wanting, they're on social media and they're still,
yeah,
it's just like a circle. It's just going to keep going. We'll be there waiting. You know?
yeah, nah, I know, but the good thing is that the education is out there. Like we saw a patient today, or not today, day before yesterday. Um, she's in her 60s, and she came with her 21-year-old daughter,
Yeah.
and so she's explanting, but her 21-year-old daughter
Yeah.
opened up and said, oh, I'm planning on getting implants, and my focus just like kind of shifted.
I
I did my
remember, yeah.
consult, and so I was like, so do you know about, like, the complications and this and that? She knew, actually. She actually knew a lot about breast implant illness. She knew about the complications from illness, and she was very torn about what decision to make. And I'm not there to make any decisions for her, but I was actually very happy that she was able to get the information and educate herself about the pros and cons of doing both. So
Sure.
yeah.
Yeah, I just saw somebody commented on how beauty standards are changing, and I think that's absolutely correct. I think women are smarter in what they're thinking as far as how people are perceiving them, and I think it's more important to be appreciated by your intelligence, and your beauty, your inner beauty
Right.
is a lot more important these days, I find.
Yeah.
To it just it almost, I think like really large breasts just almost gets in the way of people seeing the real beauty that you carry,
Yeah.
you know. So
Yeah, and you talk about things like, I mean, it's so amazing the things you learn. Like, you talk about hugging people and feeling
oh my God,
intimidated with the
isn't
implants.
that true though? The hugging, how
Yeah,
many people say, my God, I can hug people now. And I actually feel that when I hug somebody with implants, I feel their implants.
yeah,
I can feel their implants. Yeah.
yeah, yeah. Especially with contracted. The one that really got to me was when one of our younger moms was like, "Oh, I can finally feel my kid laying on my chest without the implants in there," and I was just like, "Okay, you're
Yeah.
gonna create a tearjerker moment right now." But I never thought about that. Like, I never thought about that, and I talk about that with my young moms too. And I thought that was a really special thought.
You know, this is a conversation only you and I can understand, how sometimes when we're in a room with a patient who's in tears and talking about how they just can't move forward with their life, they can't get out of bed sometimes, they can't play with their kids, their husband invites them out for a nice dinner out and they don't feel like it. And you know, they tell us these stories, and really it's like you just like want to grab a tissue, not for the patient, but for me. I'm just like, well,
Yeah.
where's that tissue? Because it's hard to hear. It's really hard to hear. But when we do see that patient and how they change and how happy they are and their kids are, it's just really, you know, I remember
Yeah.
we had a little appreciation card from a kid, a little boy. He sent you a card thanking you for
Yeah.
taking good care of his mom. And
Yeah. Yeah.
yeah, remember that?
Yeah,
Yeah.
it's a process, though. We've had patients get better right after surgery, and patients take a year to year and a half. So that's the other thing that, some patients will not get better right away. I think the things that improve immediately, which I think goes without saying, is the not having the weight of the implant on your chest, the fact that you feel like you can breathe more, not having
Yeah.
that weight on your
That's the
neck and
instant. That's what
shoulders.
everyone says that. Almost everybody wake
Yeah.
up like, oh my God, I can breathe.
Yeah, so you take that heavy backpack off of your chest and you're like, okay, this feels good. And then with all the autoimmune stuff, like the fatigue and joint pain, and that has been so variable. I mean, we see patients a week later and they feel like new people, but on average, I think it takes about 6 months to a year to really kind of circumvent that whole process. So I think that's important to know as well.
What do we say to the husbands or partners out there? Um, they're supportive, they're not supportive. You know, what can
I
we?
would say 90% are supportive. The other 10%, I always encourage them to come in for a consultation with their spouses or significant other, just so that they can discuss and understand it, because all they're seeing is what they're seeing at home. So it's good to get that. And then I always encourage the patient to get their husbands involved and look at some of the groups and kind of understand what other patients are going through. Even talk to other patients' husbands who have explanted, just to get an idea of it. But yeah, I
Yeah,
mean, those husbands or spouses that are not supportive, I mean, that is, those are tough cases, because,
yeah,
the patient feels like she's already feels like she's alone from all the things that she's been
yeah.
suffering from. And now she has to be alone through surgery. And we're there for them, but, we're not there for them,
At home.
in their house. Yeah. So I think those are really the challenging. So
At home.
I think we do a good job in kind of gauging who's going to be with them and talking about support and trying to understand what their support system is, and then kind of counseling them in that direction if we need to.
Yeah, that's a tough one. I mean, the partners are 100% a big deal.
Yeah.
Uh, you know, how they're feeling and sexually, all sorts of things that come up. Patients are really concerned for that. But someone's asking, we're going to take some questions here about pathology. Wait, what was that question? What are the toxic things you find in pathology? What percent of explanters have it?
I mean, we find a lot of bacteria in our pathology, and they call that biofilm. And so one of the papers out of Australia showed that there was a strong correlation between breast implant illness or autoimmune issues and bacteria, which kind of makes sense. If you have bacteria in the inside of your body and your body's kind of fighting it or creating this kind of chronic infection type of state, or a subclinical infection, then your autoimmune system is going to be ramped up. So we see bacteria, different types of bacteria. We've seen fungus and mold, not a lot of it, though. Even on some of the specimens that we send out that look like fungus and mold, they come back negative sometimes. So that's always kind of a brain twister for me. We see rare white blood cells, which is also a kind of immune response to fighting for the capsule formation. Knock on wood, we have not seen any lymphoma, the rare form of lymphoma that's associated with more commonly textured implants. Though we do send a lot of capsules out for lymphoma testing, and we've been sending capsules out for squamous cell cancer, and we haven't seen that,
So
luckily.
when, when we tell the patients they have the option of just leaving it up to you, whether you send out to pathology or not. So what distinguishes whether you send out or not? Like, what do you see that's
Yeah.
concerning?
Yeah, if there's abnormal masses, fluid collections, if it's sticky, there's the implant's ruptured, if there's kind of this kind of brownish discoloration, if there's any pus in there, anything that's a red flag that looks abnormal, I'm sending these things out for testing.
Mhm.
Some patients want them sent regardless, just because they want that peace of mind, and we're happy to do that. So we take cultures of the breast pocket. We can send it for bacteria, fungus, and then we send the actual capsule, the whole capsule, out to the pathologist for testing. And just for transparency, the surgery doesn't cover that. So the patients
Right.
will get a separate bill for
Yeah, that's why
pathology,
we give them
which,
the option because some of our girls are really struggling to pay for the procedure, and then they get a bill from pathology for over 700 something dollars, which
yeah,
sometimes insurance pays for that, sometimes it doesn't.
yeah.
Yeah.
So I make the decision. Somebody asked, so I make the decision to send the capsule once I examine it. Once it's off the table and I take a good look at it, if anything looks suspicious, then it's going for testing.
Mhm. Someone is asking, why is explant so expensive?
Yeah, it's a big procedure. Sometimes, I mean, these sometimes procedures can take 4 to 6 hours, and it involves a lot of technical expertise. There's a lot of materials involved. We use a lot of special type of suturing. We clean the pocket with multiple antibiotics. We use different types of solutions to help swelling. So, the cost of the surgery itself is big, and I think with adding the lift and the complexity of the procedure, taking the whole capsule out, spending time to do that makes it a very kind of technically challenging procedure. And so, national averages, and correct me if I'm wrong, but can range from anywhere from, with a lift, from anywhere from or $9,000 to $15,000.
Yeah, I don't think that I don't think on our end we're over the top. I really don't. And we do, I tell patients that all the time too. We try, uh, we're helping as many people as we can, trying to keep our costs down. Talking about costs, I know one of the big questions is like the drains. Why do some surgeons use the JP drains and some don't? Why do you insist on it?
Yeah,
Because for you, it's a non-negotiable. And then they go and
yeah,
they go and talk to Dr. X, and the Dr. X says, no, don't worry about it. There are no
sure.
drains necessary.
Yeah, I mean, when you look at our patients who have drains in, there's so much fluid production that we have to leave the drains in for 5 to 7 days. So,
I don't know how, if we wouldn't have the drains in, some patients make a lot of fluid and we leave
where would that fluid go?
sometimes over the weekend. It's like, what if they
Yeah,
didn't have the drains? Where does that
yeah.
fluid go?
So the science behind it is, the first 3 days after surgery is basically a dumping phase. So your body, blood vessels, those pipes open up and they're just dumping fluid into the surgical site to provide whatever nutrients, cells to help healing. And so, and that's all that fluid that we're collecting. And after day 3 is when these capillaries and these blood vessels start closing and you start reabsorbing all that fluid. So that's why we wait for 5 to 7 days, because we want to be confident that your body is going to be able to kind of cycle that fluid that's being produced in. And it's a big cavity. I mean, you
Yeah,
can put I mean, not to sound crazy, but you can put your whole fist
yeah,
inside the
sure,
breast
sure. I've
pocket,
seen it. I've seen it.
and if there's inflammation, there's ruptures, there's capsular contracture. I mean, your tissue is raw and it's leaking. So I just think drains are great because they just help that fluid building up there. And so, say you don't put a drain and all that fluid collects in there, then you get what we call a seroma, and then you have to go
Mhm.
back in, you have to drain it in the office. Sometimes it takes 3 or 4 attempts to kind of clean it up, and then sometimes those seromas form their own capsule. So now you have a new capsule in
Right.
there.
Our
Whether and it's
seroma
not,
rate is very low.
yeah, no, we are not covered. We have
Yes.
a good seroma rate.
Uh-huh.
But then yeah, so then it forms a capsule, and it's a different type of capsule than the breast implant capsule. But nonetheless, it can form this thick capsule that can now say stick onto your muscle and cause pain, and so it just leads to a path. It can get infected. So I think drains are necessary, and it's just to prevent fluid from building up in that space. And I always ask some of my colleagues, I'm like, so what's your seroma rate? Like, how many seromas do you have? Obviously, they do get some seromas. And the one myth that I want to kind of debunk with drains is drains do not prevent hematomas.
Okay.
Hematoma is when you get bleeding into the breast pocket. And so it almost looks like you get you have an implant back in your breast, and so you're completely swollen. And so the patient will call and say, oh my god, my drain is filling up with blood and I don't know what's going on. And then 30 minutes later they'll be like, oh, it's fine, it stopped. So the drain stops collecting blood because it gets clotted out, so the blood has nowhere to go and it collects in the breast pocket, and eventually it stops because it's a confined space. But so then we take care of that in surgery, but drains do not prevent hematomas.
Very good. We had Dr. New York City gynecologist is stopping by to say thank you for taking care of the patients that he sent. Thank you, doctor.
Thank you.
Thank you for sending us the patients. You're amazing yourself.
Appreciate it. Yeah.
Um, okay, we had someone asking about muscle repair. That's a good one.
Yeah.
So is it always necessary? What exactly is
No.
muscle repair? Like, why does
Yeah.
that come about? Like, why would someone need muscle repair as opposed to not needing it? What's the difference?
Yeah, so I decide during surgery if a muscle repair is needed. You can usually tell when you kind of have patients flex and then during their preoperative exam if the muscle's been distorted. And so there's two type of muscle repairs. One muscle repair is, so say I'm just gonna say if the muscle's a fan like this and it's been split open and the implant's been put in, then you get everything out through that split and then you close. So that's that's a repair of the muscle in the direction of the muscle fibers.
And you're repairing
Um,
that with a suture?
you're repairing it with a dissolving suture.
Dissolving
Yeah,
suture. Okay.
yeah. So you're just putting the fibers back together. And then the other type of repairs is if the muscle has been split from the bottom, and it's basically the muscle is sitting so high on the chest that it needs to be brought down and resutured to the rib cage, then that's a big muscle repair. So, and that doesn't happen too often. Sometimes it's not even feasible to do that based on the amount of scar tissue and muscle contraction. So that's another type of muscle repair. And so the recovery for both changes a little bit because,
Is that
you
patient
know,
going to be more uncomfortable than the patient that didn't need the muscle repair?
for sure. Yeah. Yeah. And they're also limited because you want to keep their arm by their side because if you start stretching your arm out, you're going to tear the muscle repair. So we modify our post-op protocol a little bit.
Correct. And
But
that's why it's so important. And I tell patients, please don't listen to what this patient said or this patient. Everyone is different. And
right.
we give them instructions depending on what you're saying. Sometimes after surgery, you'll tell us this patient's going to need this, tell her this, tell her that. So that's really important. Each surgery is different. Every patient is a different
Right.
protocol. So it's really important
Yeah.
for people to remember
So
that.
the bottom line of that is not everyone needs a muscle repair.
Right.
Somebody was asking about size of the incisions, and there was a comment about 10 centimeter long incisions. I think that's a really long incision. You can do an explant with a total capsulectomy, I think, with maybe a 6, sometimes 7 centimeter incision. You just need enough of, especially just with an explant only. With the lift, the exposure is a lot more, so the incision length doesn't really come into play. But if you're just doing an explant only, I mean, you don't have to make an incision going all across your chest to get into that. I think that's kind of an older technique to do with the smaller incision under the breast fold. You can actually have access to the whole breast pocket and go up in the middle, off to the sides, and you can get the whole capsule out safely without making a long incision. So I think yes, you can get away with doing a 6 or 7 centimeter incision.
Okay. Yeah, that's important. Okay. Let's see. Someone was asking about what about if it's a very thin capsule? Does that need to be removed?
Yeah, good. That's a good question. I mean, we take out a lot of thin capsules. My philosophy at this time is I like to remove the whole capsule. Um, you know, the we're seeing things like bacteria, biofilm on the capsule. They could be thick, thin capsules. And then you have capsules in for 20, 30 years that are thin. They're finding things like squamous cell cancer on these capsules. So I personally think, taking the capsules has a very low morbidity. So everyone talks about, oh my God, it's dangerous to take out the capsules. I don't think if you do a lot of these and you understand the anatomy, I think you can safely peel and get the capsule off of the rib cage, and do it without kind of suffering too many complications from taking the capsules out. So I personally like to take the whole capsule out. I think that's a big question of debate amongst our societies.
Yeah, I think a lot of patients have asked too. So what if I don't, what if I'm not sick? This is a question I was asked last week. What if I'm not sick? What if I want him to leave the capsule in? Like, why do you want that capsule in? She's afraid that you're going in too deep and something's going to go wrong.
Right.
So why leave the capsule? Why not? And
Yeah.
how and why does the capsule thicken? Like, why does somebody have really thick capsules, and for the same amount of time, somebody else will come in and have surgery and their capsule's super thin? Like, what
Yeah, I
happened?
mean the capsule formation is based on how your body forms a capsule. We see the capsular contracture that we see. There's a lot of known kind of thoughts behind why it happens. One is if you have bleeding after your implant placement, then that bleeding can cause capsular contracture, and infection can cause capsular contracture in there. So those are some of the readings: bacteria, infection, and fluid collections there. When you get a thicker capsule or a thin capsule, so if a patient's like, I want you to leave my capsules and just remove my implants, you can do that. That's not the surgery I personally do, or I think it's going to benefit you the most,
So
because
what if a patient is asking you to she just wants to remove for future or just for whatever reasons, their personal reasons, they want that capsule, they want you to leave it in. What would you say?
I mean, I would say go to your original plastic surgeon and talk to them about it, but that's not the surgery that I would necessarily perform.
Okay, good.
And the reason is because we have seen patients who have had those implants removed, and they have their residual capsules, and they are either feeling things. So the capsule can shrink and contract. It can cause mechanical or functional issues.
Is it
We
palpable? Would the capsule be palpable if
if it's calcified. So if it's and that's what I was going to talk about. Sometimes you can form calcifications on these capsules, and you'll see them on mammograms. And then, so we did a patient who had her implants removed 15 years ago. She still had her capsules. She kept getting these calcifications. Everyone was going crazy trying to biopsy it. And then we did a total capsulectomy, and, her capsules were the kind of culprit of what that was showing on the mammogram. So my point being is that I think it's safe and easy to do the capsulectomy. So but again, the truth is that the science is still saying we're not sure about whether total capsulectomy versus partial capsulectomy versus no capsulectomy is going to change the course of breast implant illness type things. And that was from a recent paper. Though the beauty of that is that they recognize that patients were being sick from their implants. So breast implant illness was recognized as a real entity from the implant itself, but the story of the capsule is still being kind of sought after.
So let me ask you the golden question. Do you believe in breast implant illness?
Of course, I believe in it so much so that that we stopped putting implants in like 4 or 5 years ago.
Yeah, I agree. I believe so as well.
We in Miami we don't put in implants. We don't have other surgeons who put implants in the office there. We don't carry implants in our office in Miami. So that's where we're at.
Yeah. Yeah, I'm loving our patients that are coming in and not, wanting implants. They already know. Very, very rarely. They used to come about once in a while, but they don't call anymore.
Yeah.
They don't call anymore. What was your most memorable case? Because I have one. in my mind.
Yeah.
What is yours?
I mean, I always go down to probably one of my first cases I performed. I think it was 2017 or 18 in private practice. I did a lot of explant surgery in training for breast cancer patients, and that's kind of where my techniques come from, and that's where I learned how to explant. But the one I did was she was I believe she was in her mid 30s. She had a history of breast cancer, had a mastectomy done, was in a lot of pain, had a lot of autoimmune issues, and so she was my first young patient who had a mastectomy. So we did a flat closure and an explant with a total capsulectomy on her. And we still stay in touch every so often, but that was a really memorable case because back then I was like, you're 34, you have options for reconstruction. And she just she's like, I'm going flat. And she's like, I don't really care. I don't want my breasts anymore. I don't want to have implants. I don't want any more surgeries. I'm sick of tired of
Yeah.
this.
Imagine getting to that. Yeah.
Yeah. And, I was like, so I think I did 3 or 4 consults with her. I talked to her husband and I just wanted to make sure it was the right choice. And she she's to this day she feels great and she's super happy, and so that was one that really stuck with me. I mean, there's a lot of cases. I mean, the other one was a patient who had uh, implants above the muscle and below the muscle, so she had 4 sets of
That's what
implants.
I'm thinking about. That's the one. It's like, wow. That was a really crazy case.
That was wild,
Yeah.
wild, and all 4 were ruptured. Um, I mean, and I don't think anyone has ever seen that. Somebody else has. I would love to hear from them because, you go in there and you're like, okay, you see the implant, like what's going on? So I was above the muscle. I took the implant. And I was like, what is going on? And I look and there's an implant underneath the muscle.
Wow. That is nuts.
Crazy.
Did that patient know that she had
I don't.
4 implants? I don't
I
remember.
don't think so.
Yeah,
I
I
don't
don't think
think
so
so.
either. Yeah.
Yeah, I don't think she knew.
Yeah,
I don't
that's
think she knew.
crazy. It's also crazy how so many patients, I guess maybe originally, nobody would think that their implants were coming out. And so patients would, you ask patients, what size implants do you have? What type of implants? And they'll come back and give you a number. They're so sure. And when the surgery comes about, it's like totally different
Yeah,
than what they said or what they thought. And they're
yeah,
pretty surprised at that.
yeah. We've seen people who thought they've had smooth implants have textured implant, vice versa. We found one saline, one silicone in the breast. I think for the most part, if you've had it done by a board certified plastic surgeon here in the U.S., you're gonna find what you can get in your breast. But if you're going to some random clinic it's being done by a non-board certified plastic surgeon, there's a chance you might find yourself with something different.
Okay, I'm going to just grab because it's already 8:30. So let's see. Give me 5 questions. Let's see what people are asking. Oh, here's Jamie, your first lollipop lift.
Yes,
Remember Jamie?
of course. How's it going, Jamie?
Very good. That was awesome. Okay.
Yeah.
Somebody's saying to save this video and post it. I'm definitely going to save the video and post it on Facebook because Facebook was a flop for me. So we got to try that again. And let's see. Someone's coming for Thursday. Our office, we're not closing during the holidays. We're shorter hours, but obviously Dr. Dev is always available for any issues, or I'm his first point of contact, and then we will determine if we need to escalate it to Dr. Dev. Estoy muy feliz con mi cirugía, gracias. Let's see. We have future patients. Everyone's enjoying this. I think. What do you think? What do you think, guys? Should we be doing more of these in 2024? Oh, that's a good question. So anything 2024 that patients would like a little bit more of? What can we do to keep you more informed? What can we do to make you happier? What can we do for you that we didn't do in 2023? Because every year we just want to get better and better. So we're definitely open to constructive criticism. and suggestions. If this is like our virtual suggestion box, feel free to always send
Yeah.
in any concerns or.
We do have we have three things that we're gonna do that are gonna be really helpful for patients. I don't want to disclose it yet. I think for 2024, and a lot of it's gonna be there's gonna be some video based stuff,
Yeah.
and then some things to improve. But I also want to give a shout out to our anesthesia team who has been very pivotal in helping our patients.
We're so lucky to have the best providers. Seriously, they
Yeah,
are amazing. Actually, Crystal, I asked Crystal if we can do something like this, a Q&A with Crystal,
yeah.
and she said yeah. So I think that's going
Yeah,
to
no,
be
you
awesome.
should. It's unique because one, they understand the explant surgery. They've really spent a lot of time learning about it. They've been doing it with us from the get-go. They've been with us for 5 or 6 years.
Yeah.
Their protocols are amazing because they have completely eliminated the use of narcotics with our surgery, which is really special. So none of the patients get fentanyl, Demerol, Dilaudid, morphine, which causes a lot of like kind of that grogginess after the surgery. They avoid using any gases unless it's really necessary. So everything's done through the IV. And I think there's one misconception that if anesthesia is given through the IV, it's still general anesthesia because of the amount of anesthetic that you're getting. So
Mm-hmm.
just because it's given through the IV, it doesn't necessarily mean it's sedation. It's actually a general anesthesia for these
Right.
cases.
Mm-hmm.
And then, they've come up with certain medications that they give our patients to pre-op to prevent nausea and vomiting, like the really novel medications that we're using that I don't think are being incorporated too many spaces. So we're very lucky to have them. They're always kind of
Extremely
trying to,
lucky. Extremely. I mean, our
um,
patients love our anesthesia team. And I think our anesthesia team loves our patients, which is
yeah,
awesome, And we talk about that sometimes with the patients, where sometimes patients think, is it safer to have surgery at a hospital as opposed to an outpatient surgery center? And we always talk about sometimes if they have surgery in a hospital, the anesthesia team may meet the surgeon the day of surgery.
yeah, yeah. No, we don't. That's the beauty of it. We don't have to reinvent the wheel every day. It's very, very specific. And yeah, you have the same team. The familiarity with the surgery is there. The same, our nurses are all involved from pre-op to post-op. So it's kind of like the team is really in tune with what's going on.
Mhm.
And the safety is always first. So myself, the anesthesia team, and the nurses, if there's some things that require you to have surgery done in a hospital-based setting, then unfortunately sometimes we have to make that decision. And
Yes, we
you
have to
know,
address that because it breaks my heart to have to tell a patient sometimes that we cannot do their surgery.
yeah,
Why is that? Can we explain that just, and I'll let you go shortly, but that is a really
yeah,
good question to ask you and to
mhm,
have on the record as to, it's not that you, Dr. Duff, does not want to operate on them.
yeah.
It's why is it that you cannot?
Yeah, it's safety. So, when it comes to Florida law and outpatient office-based surgery, we're only allowed to operate on a certain class of patients based off of their medical issues. So, say if you have like diabetes, high blood pressure, and some cardiac issue, we risk stratify you based off of the guidelines that are provided. And if you go into say classification 3, 4, then we just can't do it by law because if there's an issue after the surgery, then they'll shut us down. But regardless of that, it's not safe to do it. So, and then if you have high risk factors, you want to be in a setting where you have the appropriate care afterwards. So, say if you have a heart issue or a kidney issue, and that needs to be monitored after the surgery, so you get admitted to the hospital, and you're in the ICU or you're in the surgical floor, and you have the appropriate teams following you. So you have to spend some time in the hospital. So it's not because I don't want to do the surgery. I've done tons of surgeries in the hospital, and
Mhm.
it's for safety reasons more than anything else. So we have to really stratify our patients and follow the laws and the rules of what Florida mandates us.
Thank you. Thank you for clarifying that. That makes my job easier.
Yeah.
Well, I think we'll close off now. That It's a little bit over the hour, and I appreciate your time. I appreciate coming on board for my first interview.
Of course.
And,
Happy 4 year coming up, and you know,
thank you. I'm so excited. I'm still 100%, 1,000% grateful for
yeah,
my surgery as a patient. I can tell you that I'm still super happy. I'm still in awe of the results. I'm still grateful that, and even I'm grateful to all the other patients before me, all the patient advocates, because I think sometimes I've gotten a little bit, I don't know, criticized or hit hard because I was not a breast implant illness patient. And I did this procedure as a preventative, and but because of these patients that did have the procedure done and were not well, I was able to come to the conclusion that it was the right thing for me to do. And I'm super happy that I did do it. I'm still 100% happy, and that you were my surgeon. You're my favorite surgeon. So thank you very much. And I love working with you day in and day out. 2024 is going to be amazing. We had a great year. We met some fabulous patients, and we definitely appreciate everybody that walks in through our doors on a daily basis. We appreciate, we have an amazing team, from Monica, who answers the phones, to anesthesia, to nursing, to coordinators. And I'm just really grateful for the amazing team, because without this team and the cohesiveness that we have, we couldn't provide the service that we do. So thank you to everybody. Thank you to the patients, our staff. Thank you for everybody that's watching, our little spies out there, everything. Thank everybody. It was an amazing year. 2024 is going to be even better, right?
yeah, no, we're looking forward to good times. Well summarized, and no, I'm glad you did this, and we look forward to helping a lot more patients, and we're very passionate about it. So we're
Yeah,
here for you guys. Thank you.
definitely are. Okay. Good night, everybody.
Good night. See you tomorrow.
Ciao, ciao. I might be in a little late tomorrow, okay?
I won't be.